into small spaces and stuff, and having small bleeds is not uncommon for them. So basically they die of hemorrhage. And if we have a child with an ingestion of one of these, so there's different forms. Some of them are blocks. Sometimes there are little bins of pellets. And it's pretty common for a kid to try to eat a pellet or two. They usually don't eat that much. The problem with them is that people tend to put these where the rats are, like along the edge where they run along the side between the wall and the floor, kind of the same places that children go. And so it's pretty common for kids to try to encounter these and maybe take a nibble of them. The vast majority of kids really have no issue with it. They never get sick, they never get anticoagulated because it doesn't taste very good to people, although it's designed to taste good to rats. You can think about GI decontamination. I wouldn't be too aggressive with this, but if the parent can get the child to take some charcoal, that's probably worth doing in case the child actually did take some of the stuff. And then you want to check a 48-hour coag, right? Just like warfarin, the super warfarin, it doesn't make you get anticoagulated quicker than warfarin does, but it just lasts longer. So just like warfarin, you can't just check an INR right after you took it because it's not going to go up right away. It takes a while to deplete your vitamin K dependent factors. So you can get a baseline. The only reason to get a baseline that I think is reasonable is that people will sometimes say, well, maybe the kid's been doing this all along and this is just the first time you caught them. I've never yet seen an abnormal baseline coag on any of these patients, but it's something that a lot of people advocate for. But more importantly, they need to follow up with their pediatrician in 2 days to get a repeat INR to make sure that it hasn't been elevated. If it is elevated, you're going to start vitamin K, and they may need very large doses, and they may need to be on it for months. So this is why we don't just give vitamin K, right? Because you could just say, oh, why worry about it all? Just give everyone vitamin K. But some of them are going to really need big doses, and they're going to need it for a long time. And the vast majority of kids get nothing after this because they didn't really take it. They were just found next to it, or they just took a pellet, and that's all they took. We want to identify the ones that really did because those have the potential for illness. There's some published reviews of this subject that advocate that you don't need to do anything because so many kids really didn't take it, and this kind of goes back to what I talked about before about the difference between exposure and ingestion. But there's no reason to think that if a child actually ate some of this stuff that they're not going to get sick. So we want to check them all and identify the ones who really took it. In terms of cholecalciferol, it's basically vitamin D, and the rats die of hypercalcemia. There's no case reports even of human toxicity from cholecalciferol rodenticide, but there are plenty of cases of children that get vitamin D supplements in overdoses that get hypercalcemic, so it is at least a potential risk. I'll briefly talk about hydrocarbons. I know I'm slightly over time, I apologize. And just mention that there are a lot of household products that do contain hydrocarbons and their potential risks. And the main thing about hydrocarbon toxicity is that it's multi-organ system toxicity, but the most typical one we have to worry about in the emergency department after most household products is aspiration. There are some that can cause neuropathies and can cause hepatic toxicities. Those things aren't in most household products. It's also really common to have some vomiting after ingestion of a lot of these things, which is a risk for ones that are easily aspirated. And aspiration pneumonitis is the most common manifestation, I just said that. And it's even been reported after intravenous hydrocarbon exposure, which is usually going to be a psychiatric adult patient rather than a pediatric patient. The 5 V's of hydrocarbon aspiration, aspects of hydrocarbon poisoning that make you likely to aspirate the hydrocarbon. Anybody know these? Viscosity. Volume, right? If you drink more, you're more likely to aspirate it. Viscosity, thinner or thicker, is more likely to be aspirated. Thinner. So lower viscosity, right? Just think about elderly patients with difficulty swallowing. You add thickets to their feeds so that they don't aspirate. What else? Volatility, yeah. So more volatile is more easily aspirated. Vomiting, right? If you puke, you're likely to aspirate. And then the last one, van der Waals, which nobody ever gets. It's basically surface tension. Surface tension is the propensity for something to stick to itself. Like water has a lot of surface tension, so you can see it bead on the surface of a wax car. So if something has a lot of surface tension, as it makes the turn in the back of your throat after you swallow some, it tends to follow itself, whereas things that don't have high surface tension tend to break up into little droplets, which is easy to understand would be more easily aspirated. All right, so this is a child with hydrocarbon aspiration. Basically, it just kind of looks like any pneumonitis. And most kids will have some kind of coughing or gagging or choking initially, and usually they'll have some symptoms within 30 minutes. Tachypnea is common, and absence of that has 80% negative predictive value, which obviously is not good enough to discharge a child. And the most important thing to take away from this for hydrocarbon aspiration is that initial chest x-ray is not reliable for excluding aspiration pneumonitis. It can be delayed, so you got to delay your chest x-ray by 4 to 6 hours after ingestion. Skip that. And then we've talked about this many times before, but halogenated hydrocarbons can cause myocardial sensitization and prolong your QT and cause torsade. I'm going to skip toxic alcohols because we've talked about that before, and we'll talk about it again. And just sum up. So for a few toxins, one pill is potentially deadly in a child and might mandate admission even if they're asymptomatic. Some exposures are so non-toxic and so low risk that they don't even require a hospital evaluation. You can distinguish mothballs with using just salt and water, but really clinical determination is more important after a mothball exposure. Iron ingestion is becoming concerning when there's more than 15 mg per kg of elemental iron, or if the level is over 500 mg per deciliter. For rat poison ingestions, the most common ones are superwarfarins, and you want to check a 48-hour INR. Hydrocarbons cause aspiration pneumonitis, and halogenated hydrocarbons cause dysrhythmias, and we didn't talk about the rest. So, any questions? All right, thanks again.